Hello, my name's Dr Anna Pietzsch. I work at the Sunshine Coast University Hospital, not far from here in sunny Queensland, and I'm with Vanessa Beavis, who has just presented an amazing plenary session on perioperative medicine. So, welcome.
Thank you. Lovely to be here. Here's the sun.
Yeah, exactly.
Yeah.
I'm really interested on a hospital-based level. I've been proudly grandparented into the chapter of perioperative medicine. And I'm really interested in the way that we can use the chapter within our hospital, specifically for the way that we build a provisional fellowship program around perioperative medicine. How do you see that happening in the future?
Perfect. I mean, that's the perfect place to start it, actually. Every hospital is different in terms of where you're up to in establishing, the little nephron, famous nephron, as to what you've got and what you don't have. So the good thing is you can just pick bits out of that, and then you've got your program. But then, of course, that's very nice, but you need people to do it as well. And so that's where the provisional fellows come in. And if you do have a perioperative fellow program, this is the absolute ideal thing. In fact, we're hoping that there will be a lot of people who will try and pick that up, because if you think about it, there's 6 specialised study units. It's done in 3 trimesters, similar to university trimesters. It takes about 40 hours of study per unit, as well as 40 hours clinical immersion. Yeah. And so with people who have been grandparented, who act as supervisors and volunteers to look after the people doing the qualification, it's just absolutely ideal. We're doing that in my hospital. We're thinking we can get people through in the year that they are a fellow, and so far the feedback has been amazing. We've got 3 people. We're oversubscribed. And so that's the only thing, you have to, in fact, we're in a fortunate position being able to temper the numbers. So there's a great need and a great desire to do it.
Yeah, absolutely.
So you can do it, yeah.
It sounds incredible. I know in my hospital we've launched that position, and the hardest part we found is finding a way to direct them. So absolutely, leaning on the chapter will be incredible for us. Okay.
It gives you a structure.
Yeah.
Because, uplifting medicine, what is that? Oh, it's this bit and this bit and this bit. Well, okay. When we worked out the definition of perioperative medicine, it took us a year to work it out. And that was in 2003, granted. Yeah. But nevertheless, it's just rolls off everyone's tongue. Everyone knows what it is. But there's a hard concept to kind of nail down. And so you'll do it and refine it. And we're much better as you go along.
You probably took the words right out of my mouth, because the perioperative provisional fellow role, it's exactly what I found is it's a great idea, and I know it's a good idea, but actually kind of anchoring it in something's been really difficult. So I think we'll find the chapter really useful.
And then work out what the measures of success are.
Yes.
So that you know what to aim for before you start. Otherwise, it's going to be, we want to get one person through. And in that time, that person, apart from doing all the study and everything else, is going to set up some liaison with some other group or some concrete focus, patient-focused outcome. Yeah.
Great. That sounds really incredible. Okay, my favourite question. If you had an unlimited budget and tomorrow your health service said, Dr. Beavis, you can do one thing for perioperative medicine at a hospital-based level, what would it be?
Unlimited budget.
Yeah. A big coffee machine.
Yeah. Okay, coffee machine and cake. But apart from that, in my hospital, that would probably be considered a big budget. I think I would start to focus resource into the post-operative period, because we've got a fabulous acute pain service. And so the model is there, and for people to consult, but not actually be, to provide advice, not actually providing the hands-on care themselves. Yeah. And I'd like to expand that model, because I think, judging from what I know about it, that's where all the problems get picked up. It's not every single patient that's going to need this, but I would like much more focus in that area. That's the one thing, to rescue people in the ward or before they need rescue. So to identify the problems. And secondly, of course, like everybody, more HDU beds or sort of an advanced recovery, as in Adelaide, or otherwise, as we used to call it, long stay recovery. Because we were finding for us, for example, we'd have a whole lot of patients who'd come through and would kind of ward fit. They didn't meet the criteria for PACU discharge. So we'd end up keeping them. Well, I want to formalise that. We did do that actually, but it sort of slipped away. So let's get the money again and formalise it under the care of anaesthetist, and then back to the ward. And the data are absolutely clear.
Yeah.
It's a fabulous initiative for patients.
Yeah, it's definitely what I was thinking about during your plenary session, was that we all see our role in that preoperative, preparation and prehabilitation and optimization. But then we sort of, in recovery, we sort of tend to kind of drop our patients there.
There you go.
Yeah, absolutely. And we all know that that's when the complications happen. So it's been something I'm definitely thinking about how we can apply that to our hospital. I'm looking forward to sharing your budget. Okay.
That's good. Yeah.
As a more general question, your biography is obviously incredible and inspiring and amazing. And you've had, so many different roles at a hospital, kind of national and international level. I'm really interested in what the most memorable, the thing you're most excited about that you got done while you were the ANZCA president.
It was an amazing time. It really was. But of course, it was COVID though. So I think the thing that really, I can't say really achieved anything majorly, but I think I prevented the whole thing from imploding. Because when you think about the terrible pressure that everybody was under, I mean, in a clinical sense, we all thought we were going to die at first, because we looked overseas and saw all of that stuff going on, terrified for our family. So that was all the personal kind of thing. And then there was the college, and we had all these trainees who were trying to get through the exam, and the health orders would change every 5 minutes, and you just thought you had something sorted, and then, oh my God, some other person did something else, and they were all different as well. And so we just sort of set course and speed and decided we were not going to have failures in the exams, for example, like other colleges had tried things which were disastrous and even worse for their trainees. And so I think getting with the stuff that was going on and getting everybody to change, and I hate this word, but pivot into being able to get our trainees through the training program to allow progression and keep the pipeline going and provide some certainty for them. I think that was, and it was such a team effort. It was unbelievable. Yeah, okay, I was the president, but chair of exams, Michael Jones, I mean, the work that he did with the examiners and the chairs and the college staff. I mean, we had the college staff driving around with the papers to deliver them to the SOTs at the different hospitals. And of course, that all required police permission to do it and all that kind of stuff. I mean, it was amazing. The day before, when South Australia went into lockdown, and there were 3 candidates who were it was the day before the Vivas. And we just, I sold my left kidney about 5 times. But anyway, we managed to get those 3 candidates to New South Wales to sit their final exam, and the college did all of that. And it just couldn't have happened without this massive machine. And all the stuff that we just, we never thought about the exams. Oh, yeah, it's exams, they're busy with that now. And suddenly our whole focus had to turn right back to the basics. And it needed the entire college to do that. Think about all the comms that went out, all that. It's just, it's massive. So yes, COVID. We survived COVID. We got our trainees through. No one died.
Amazing.
Yeah.
It's interesting. Probably the thing that I'm going to take away from the ELC mostly is about how much the college does care, and the stories that I've heard about people genuinely caring and wanting the best for their trainees to get them through. It's actually amazing to think how many people were actually working in the background, making that happen. And if I ever introduce you again, I'll be like, Dr. Beavis, she prevented implosion.